Greetings, everyone. Welcome to the next in our series of Public Health and the Legacies of Chattel Slavery webinars brought to you by the Center for Reparation Research. I want to greet the friends of the Center for Reparation Research, the members of our advisory board, the network of scholars, and to welcome you most of all to our very own University of the West Indies, the Mona campus, which recognizes and declares that the land on which we operate as an institution of higher learning is the original or traditional territory of many peoples. The UWI acknowledges the First Nation comprising the indigenous people who were displaced by the Columbus Project and general European colonization, and the hundreds of Africans who toiled for more than 100 years as enslaved people on the old Papian sugar estate. The UWI recognizes their labor and sacrifices in preserving this land that has enabled the establishment of a university that now provides opportunities for many of their descendants to receive an education that they themselves were denied. I want to start by acknowledging that the work we do at the Center for Reparation Research in supporting the CARICOM Reparations Commission is centered on the CARICOM Reparations Commission's 10-point plan of 2013. It has offered the Caribbean a common blueprint to analyze the lasting legacies of chattel slavery in the region. We see that CARICOM 10-point plan as a development plan which details various areas for repair necessary to achieve a stable society which can surmount the challenges of the past, specifically within the boundaries of the plantation. So the center, through its mandate of education, advocacy, and research, we aim to create a space for interdisciplinary discussion about the whys and hows for achieving fundamental development goals. And if you had joined us in the first webinar we staged on October 31, first of all, you can find the recording on our YouTube page, the Caribbean, let's say the Center for Reparation Research's YouTube page. We will also, just to inform you, post this webinar on our YouTube page as well. Now, I want to also say that the case, as you know, for political reparation must consider the need for physical reparation in the post-colonial context when we place concerns of underdevelopment into focus. And this is the reason why we bring you conversations about public health. Physical reparation, the whole question of wellness, becomes important, considering that as part of our development challenge in this post-colonial world would be the continued oppression through extractive relationships, resulting in low healthcare benefits, certainly the rise in non-communicable diseases, NCDs, in the region, and the need for attention to several sorts of maladies affecting the physical body. In our last webinar, for example, we heard about prostate cancer and the rise in testosterone following the theory, anyway, around the rise in testosterone following the trauma of the transatlantic trade in enslaved Africans. We also heard about the need to define public health on our own terms, and as well, the whole question of Jamaica's food history and the need to engage with a conversation, an indigenous conversation about wellness and food culture. So we thank Professor William Aiken, Dr. Natalie Greaves, and Dr. Nicole Plummer, our first webinar speakers. Of course, today we are joined by three distinguished speakers, and I want to just introduce all three of them at the same time and in the order that they will speak to us today. So for Public Health and the Legacies of Chattel Slavery 2, we have Dr. Judith Blanc, who is an assistant professor of psychiatry and behavioral sciences at the University of Miami Miller School of Medicine. She's also head of community outreach at the Center for Translational Sleep and Circadian Sciences. She directs the Holistic Families Lab and employing innovative approaches to address stress responses in marginalized families. As a principal investigator on several National Institutes of Health funded studies, her research focuses on chronic stress, trauma, and resilience with over 80 publications. She's also a member of Haiti's National Committee on Reparations and Restitution, to which she contributes to the study, certainly, of the psychological legacy of slavery, recognized as a top academic work. Her work has been featured in leading journals and media outlets, including the American Psychologist, JMA Network, and CNN. I now introduce to you Dr. Nancy Crago, who is Professor of Social Epidemiology and American Cancer Society Clinical Research Professor at the Harvard T.H. Chan School of Public Health. She is also director of its interdisciplinary concentration on women, gender, and health. An internationally recognized social epidemiologist, she's engaged in health justice work, and her background is in biochemistry, philosophy of science, and history of public health. In 2021, she was appointed to the UNESCO International Scientific Committee for the Roots of Enslaved Peoples Project, and in 2023 was awarded the Sedgwick Memorial Medal by the American Public Health Association, its oldest and most prestigious medal. I now introduce Dr. Dave Goss, who is a senior lecturer and current director in the Institute of Caribbean Studies at the University of the West Indies Mona campus. He's a graduate of Howard University, and his first book on abolition and plantation management in early 19th century Jamaica was followed by his second book on Alexander Bedward, The Prophet of Augustown, Race, Religion, and Colonialism. He is also the author of several publications, many which have been cited by historians and cultural scholars around the region. Please help me to welcome our three distinguished speakers, and I'll ask Dr. Judith Blanc to proceed with her presentation. The platform is already enabled for sharing.
Thank you so much. Good afternoon, everyone. Can you see my screen?
Yes, it is coming up.
Perfect.
There we go.
I don't know what's happening, but I feel like my computer, okay. Can you?
Yes, we can see that. So you need to just centralize your presentation.
Okay, just a moment. Okay, so I'm going in presentation mode. Let me know when you see it.
Brilliant, it's up.
Yes, yeah.
Okay, thank you so much. Thank you for your brilliant introduction. I'm so glad, so happy and honored to join you today for the first time at the Center for Reparation Research, University of West Indies. And so I really wanted to at least acknowledge my colleagues because without them, I would not be able to join that stage and to talk about our research, our study that we just studied a couple of months ago. So a public health approach to generational healing and reparation in Haiti, it's really a preliminary insight findings that I'm presenting as part of the historical multi-generational traumas and health reparation working group of the as part of the Comité National Haitien des Restitutions et des Réparations at the State University of Haiti. And here you have the colleagues who are part of that working group with me. Of course, you don't have an exhaustive list of that committee here, but I wanted at least to acknowledge them. So without further ado, so these are the major takeaways that I hope you will gain from my presentation. But first, let's dive in briefly in the historical context of Haiti, right? So when it comes to analyzing the Haitian crisis or within the global context of the reparation movement, it is important to remember one thing. There are, of course, similarities between Haiti and other Caribbean nations, right, and also other countries in America that have been colonized by European powers. But it's also important to remember the singularity. The first one, for example, is the fact that prior to the 1791 revolution, 750,000 captive Africans were dragged to colonial Haiti through the slave trade. The mortality rate of slaves in Haiti was higher than anywhere else in the Western Hemisphere. And French plantation owners were so harsh that half of the slaves died within a few years after arrival. So alongside of this story, of this history, personally, I counted about 15 major other stressful big events that happened in Haiti between the invasion of Christopher Columbus of colonial Haiti, formerly known as Saint-Domingue, between 1492 and today, including the independence ransom, including the occupation by about 30 years of occupation by American power, right? And several political upheaval and natural disasters. It's like we just cannot take a break. So now, what does that mean within the context of our webinar or within the context of our work that is placed in the context of public health or the consequences of the health consequences of the exposure to the slave trade or this huge crime against humanity? So my work really is centered around health disparities and health equity, right? So today, in modern society, we have overwhelming evidence showing that everything that was happening since Christopher Columbus invaded America, including Haiti. So those historical social structures, particularly with the racialization process, racist social structure, sexist social structure, they are strong determinant of our social experiences, such as the quality of the food that we have on our table, right? And also the quality of the air that we are breathing, as well as, I'm sure that you're probably aware of what's happening in Haiti, the level of gun violence that you're exposed to, and your ability also to move freely in the space. So the hypothesis behind this research is that those social experiences, at some point, they may interact with your gene function and thereby influence your health trajectory and modify disease risk factor before you are even born until you die. So when it comes to Haiti, let's go back to the Haitian context, right? So recently, there has been the call for reparation and the restitution of the independence ransom is gaining momentum. And we do also have compelling statistics that can boost a Haitian global reparation movement. Haiti faces significant challenges in health, education, economy, political stability and instability. While France have some challenges, but here, for example, in table 1, I personally, gathered those data, and you can see the discrepancy, the scandalous discrepancy between Haiti and France when it comes to health in general. For example, starting from the almost 20 infectious disease outbreaks that happened in colonial Haiti. Same thing, same disparity is also observed when it comes to life expectancy. For example, the average Haitian will live up until 64 to 8 years, while the average French will live 82.3 years, right? The same disparity is observed in life expectancy for women, for men. Same thing for child health, maternal health, mental health, cardiovascular health, cancer, right? The level of exposure to homicide, armed violence, the mortality rates, the healthcare coverage that you have access to, gender-based violence, and also feminicide. So the problem that my work and the working group that we constituted that focus on historical trauma, multi-generational trauma as part of that committee in Haiti. So we are trying to see how, amid the ongoing political crisis and the growing demand for France to return the independence ransoms to Haiti, our goal is really to advance data on how restitutions, reparation could impact Haiti's public health infrastructure, or how healing programs could be effectively implemented. So first, one of the first steps, we are promoting a biopsychosocial ecological paradigm when it comes to reparation efforts. So here, I hope we'll have enough time to talk a bit about some data. So I leverage an ongoing platform called the Haitian Wellbeing Study, which is a longitudinal study of about 10 years that I studied at the University of Miami. So we are currently conducting quantitative survey. We conducted qualitative analysis last year. By the way, in the next slide, you will be able to scan the QR code to download the paper. And when in the context of this presentation, we also leverage secondary data analysis for the comparative study of health indicators between France and Haiti. And at the end, I am presenting the return on investment of the restitution fund. Again, this work is being conducted in the context of the Haitian Wellbeing Study. And so basically, I won't have really enough time to talk about what came out of the focus group, but for sure, the most important thing was that people were in huge distress, mental health. There's a mental health crisis going on, and people just want the country to be rebuilt, and they want the security. They want security to be reinstated, and they really want a public health program that focus on mental health. So building on that, so I use artificial intelligence, of course, to conduct a comparative analysis of estimated impact of restitution at a level of 30 billion, knowing that, okay, for example, some famous economists estimated the independence ransom at 30, around 30. That doesn't mean that's the right number, but because the 90 million franc that they took from us, based on some math that a famous economist, so a French economist conducted, he said, okay, it's up to 30 billion. But as part, one of the mission of our committee is to really revisit that number and see how we can take into account global components to really provide an actualized estimate of what they really owe us in terms of the independence ransom and also reparation for slavery. So what do we see here in table 2? Here you have a summary of projected health improvements in Haiti through reparation-based investment. For example, for key health sector, studying from the historical legacy of infectious disease that we are still dealing with, that which started with the colonial era. So we could have major reduction in infectious disease like cholera and malaria with substantial investment in public health infrastructure. The same improvement could be also noticed when it comes to life expectancy. For example, this could be increased from between 78 to 80 years over 10 to 15 years with a 30 billion, assuming a 1.5% increase and 1 billion invested. So same improvement that we notice through this return on investment in the Haitian healthcare system for male, women life expectancy, child health, maternal health, mental health, food, prevalence of infectious disease, cardiovascular health, cancer rates, and so on. So since I know I didn't have a lot of time, but I just wanted to conclude by sharing this call to action. First, the committee, we are really grateful. We are really thankful because we have received a lot of support from the Reparation Movement Network throughout the Caribbean and through the African diaspora. I wanted to underline the fact that centuries of physical and psychological aggression and injuries stemming from race-based slavery and colonial oppression continue to affect the Haitian population today. This is important to remember. The impoverishment, social inequities, and lack of healthcare access in Haiti they are rooted in colonial exploitation, which perpetuate health disparities. So to conclude, in my opinion, a global reparation and restitution movement should therefore go beyond a moral and symbolic recognition in the financial compensation to address these environmental factors that continue to harm the Haitian population. So thank you for your attention. And so after everybody finished will be speaking, so I'm open to discuss with you those insights. And here you have the QR code. The insight I just presented, I just shared with you, is part of a preprint publication that I have that's available online. If you want to learn more about the subject, you can scan the QR code to download the paper. Thank you.
Thank you so much, Dr. Blanc. I certainly enjoyed that. I want to thank you for sharing the preliminary results of that study with us, and for also positioning Haiti's own case for reparatory justice in respect of health. This is one of the, let's say, unique areas that we are not necessarily considering when we talk about the trillions that have been calculated, for example, in the Brattle report, that health as a discrete area needs its own focus. And so I really want to thank you for that. The historical sort of multi-generational traumas are really, in a sense, because they seem to be invisible. Unless we're looking at the statistics, for example, in relation to NCDs and so on, we're not necessarily focused on the legacies of chattel slavery, the legacies of these traumas on physical wellness, on mental wellness. And I particularly like the fact that you highlighted the need for this public health program to address mental health. The estimates of 30 billion, I'm sure, would be quite conservative, let me say, but we're going to be able to talk a little bit more about that. So let me invite Dr. Krieger now, Nancy, to do her presentation.
Thank you. Thank you very much. My name is Nancy Krieger, and as mentioned, I'm a social epidemiologist based at the Harvard T.H. Chan School of Public Health in Boston, Massachusetts, and a member of the International Scientific Committee of the UNESCO project, Roots of Enslaved People, which is led by Miriam Kotias. And I'm honored to share with you today the book that I and the editorial collective listed here to have put together as part of a book series that is being produced by the UNESCO project. In brief, the mandate for the book project was to produce a book with reprinted articles or chapters about the health impacts of the transatlantic slave trade, with brief introductions to put each article or chapter in context. Each book will be published in French, Spanish, Portuguese, and English. And so with this image on the screen of the roots of the transatlantic slave trade and the number of enslaved Africans arriving on the American continent between 1514 and 1866, and also their number in relation to the flags of the ships in which they were forced to embark, let me share with you the brief introduction that was collectively written by all the co-authors in this volume, and then I'll share with you the table of contents. So here's what we wrote. Typically, discussions of the horrific harms, including health harms of the transatlantic slave trade, look to the past when slavery was legal. These harms, increasingly well documented by historians and other scholars, span from deaths and disease attributable to the seizure and enslavement of persons in Africa and those who died fighting against this enslavement, on through the terrible tolls of the Middle Passage, and thence the brutal working and living conditions of those who toiled, resisted, gave birth to children, and were harmed physically and psychologically, and died as enslaved persons in the Caribbean and the Americas. But connections between health and the transatlantic slave trade do not lie solely in the past. As we document in this anthology, they extend to the present. And as we also document, these harms and those who created these harms never went unopposed. During the centuries slavery was legal, there were witnesses and analysts who described slavery's manifold harms and challenged racism, including the scientific racism that enslavers and those who benefited from the slave trade used to justify this pernicious system of labor exploitation coupled with cultural genocide. Dominant dogmas upholding so-called white supremacy and so-called racial inferiority of other quote-unquote races as alleged quote-unquote natural facts have always had their trenchant critics who have exposed the empirical and conceptual flaws of these racist systems of thought and practice. Such critique, a form of resistance to slavery, are not a new idea. Abolition of slavery did not end the embodied health harms of the transatlantic slave trade for two reasons. First, in the economic and social realms, those who had accrued wealth and power via owning enslaved persons found new ways short of slavery to entrench and enforce racialized exploitation and oppression, in part by preserving the economic assets and political power of those who had been enslavers. Examples include remunerating enslavers for their quote-unquote lost capital after slavery was abolished, as occurred in the French Caribbean, with the yoke of these debts generating centuries-long repercussions, as we've just heard, for Haiti's governance, government coffers, and social spending. And also by creating new legal systems of racial discrimination, such as Jim Crow in the United States. Second, in the embodied realm, the health harms of the slavery system have continued to wreak havoc on descendants of enslaved persons and on the ecologies of the areas in which plantations and enslaved labor were employed. This is for two reasons. First, the direct impacts of inequitable and harmful social and biophysical exposures occurring where people live and work across the life course in each generation, including on people and also developing fetus. And we would like to note, too, that empirical evidence does not support the hypothesis of epigenetic inheritance via gametes of health harms across generations. That's a longer discussion point. And the second reason is the persistence of ecosocial system damage over time. In this multi-century, multi-country anthology, we have sought to present a mix of primary and secondary documents. As for who this we is, we are an interdisciplinary and multi-country team of collaborators convened to work on this project under the aegis of the UNESCO program, Roots of Enslaved Peoples. All of us live in locations involved in the transatlantic slave trade, North America, both the US and Canada, the Caribbean, Puerto Rico, South America, Brazil, and Europe, Portugal. Several of us are descendants of enslaved people, others are European or descendants of European immigrants to these locations. Our various disciplines include social epidemiology, global health, nutrition, medicine, public health practice, population health, social science, and history of public health, medicine, and science. Collaborating on this project has reinforced the value of bringing together a group of scholars and practitioners diverse in both expertise and lived experience. Our 12 selections span from the early 19th century CE to the present, with a geographic scope ranging from the African continent to the Caribbean and the Americas. Each selection documents and analyzes the health harms imposed by the transatlantic slave system during and after when slavery was legal. Each selection also stands as an expression of resistance to these harms, whether by marshaling the arguments and evidence against health injustice or by describing the work of medical and public health practitioners dedicated to advancing health justice. The cumulative impact, we hope, will be to encourage you, the reader, to identify and seek new ways to work with others to rectify, including via reparations, the deep links between present-day health inequities, population health, environmental crises, and the transatlantic slave trade. So let me share with you the table of contents shown across 2 slides. As you can see, our entries start in 1814 with an excerpt from de Veste's The Colonial System Unveiled about the brutality of slavery in Haiti, followed by an 1859 article by Dr. James McCune Smith, the first credentialed African-American physician, challenging the scientific racism of Thomas Jefferson. Next, excerpts from the path-breaking textbook in 1883 by Dr. Rebecca Crumpler, a book of medical discourses in which she is the first African-American woman to be awarded an MD in the United States, discusses healthcare feasible and appropriate for Black women and other women with few economic resources. And this is followed by excerpts from chapters from the 1899 opus by W.B. Du Bois, The Philadelphia Negro, in which he provides historical and social context to explain the health status of the Black population in Philadelphia 35 years after emancipation. We then move to current scholarship about the past, with all of the articles engaging with the adverse health impacts of the transatlantic slave trade from past to now. The first article, published by Hunt Kennedy in 2020, analyzes disability rhetoric and the challenge of revolutionary emancipation. The second, published by Pimenta and Gomes in 2022, provides new data from Brazil on what they term the, quote, appalling mortality, end quote, revealed by new analyses of data on disembarkation, demographics, and African diseases. Next, we have a chapter by Mwazi in 2022, which analyzes the experiences of enslaved wet nurses in 19th century Brazil. This is followed by a 2022 article by Reese analyzing data on the legacy of slavery and contemporary life expectancy in the US South. We then have a 2021 article by Polidoro et al. On the current impacts of COVID-19 pandemic on Brazil on indigenous and Quilombo peoples. A 2022 article by Boum Mackay focuses on the French government's role in the terrible pollution in the French Caribbean by the carcinogenic pesticide chlordecone, leading to horrific rises in prostate cancer now. A parallel 2021 article by Kang about environmental sacrifice and resilience in Louisiana's Cancer Alley looks at the links between the plantation economy, the current petrochemical industry, and the inequitable harms both to people, including descendants of sharecroppers themselves descended from enslaved peoples, and also to the ecosystems. The final article by Muhammad, published in 2021, provides a social history of sugar as tied to the slave trade and its contemporary adverse health impacts worldwide. In other words, the harms caused by the transatlantic slave trade system to people and to the ecosystems in which we live and on which we depend were evident when the system was in effect, and they persist to this day. Our book pulls together articles that reveal these embodied harms and embodied truths that matter in both courts of law and in court of public opinion, and are relevant to the work of reparations for people and for life on this planet. Thank you, and I'm happy to answer any questions you have in the Q&A.
Thank you so much, Nancy. I think that the positioning here, certainly centering the work being added to the arsenal of materials being published under the auspices of the UNESCO Roots of Enslaved Peoples Project is vital. The more sources, the more we are able to make the case against things that have been so staring us in the face almost, scientific racism, health injustice. I want to invite everyone to seek out the scholarship being generated that centers the work of reparation, the work of repair, that we must do on the basis of solid scientific evidence. The themes are consistent, I think, across the two presentations we've heard. And the more evidence we have, the more of a case we will be able to make for the obvious transformation necessary in and among post-colonial societies within the African diaspora in particular. So I want to thank you certainly for that insight. The next presenter, Dr. Dave Goss, and please let me remind everyone in our webinar, please place your questions in the Q&A, in the chat, as we now allow for Dr. Dave Goss's presentation. And I must tell you, I'm quite excited about this work. This is work that I have myself engaged with because I did a review of this work and specifically chose Dr. Goss because these are things we don't often think about. So over to you, Dr. Goss. You're muted if you're speaking.
Mute. Sorry.
There you go.
Yeah,
So you might want to also put it in presentation mode.
I think I have it in presentation mode. Are you seeing it? All right, let me just, yeah?
Right, there we go.
Yeah, beautiful. All right. Yeah, so greetings everyone. Thank you for the privilege of sharing research. It's always a joy to share. And also a joy to be on this particular program with Nancy and Judith. So greetings. So I'm looking on lunacy in the 19th century Jamaica as it relates to public health. And I'll start first by highlighting that there's a 1895 trial of Alexander Bedward. Alexander Bedward was a revivalist preacher, very popular in Jamaica and in other Caribbean islands as well, and was like public enemy #1 for the colonial authorities. So they tried him for a sedition in 1895, and it provides a good analysis of the role of lunacy as an important tool of social control. So in 1895, at the end of the trial, the judge, in influencing the jury, informed the jury that if they found him guilty for sedition, they could charge him as a lunatic, and the jury did. But Bedward's lawyer had him acquitted because the 1861 lunatic law stated clearly that a medical doctor had to examine you for lunacy before you could declare someone a lunatic. So it's quite clear that it was embarrassing for the Jamaican colonial government. So embarrassing that the governor of the island wrote to the colonial office, and this is what he wrote. He says, under our lunacy law, we cannot deal with him, this Bedward. We can only continue to observe his sect carefully and rearrest him in the event of him preaching in sedition. I do not apprehend danger from himself, but he may be used by others of creating disturbance among people so excitable and ignorant as our population. So by 1896, then, Jamaica government now strengthened the lunatic law. And what is interesting here, that they created a new form of the law, which is called criminal lunacy. And if you examine the figures of persons going to the asylum after 1895, you'll see about a 300% increase of persons going to the asylum after 1895. Now, under this new section of the law, it had 16 provisions. And just some of the provisions gave the police, justice of the peace, to declare someone a lunatic if they thought so, detain the person, and then the doctor would do the rest. The governor could also declare a space as a lunatic, a place of lunacy, and detain everybody, arrest everybody, send them to be incarcerated, and then the doctor, medical doctor, would give his verdict. So I'm going to show two tables here then, a table 2 and a table 3. what table 2 actually shows how under lunacy, a number of social problems were now categorized as lunacy, right? That's what table 2 will show. So I'm going to go to table 2, and I hope it can be seen, but I just will go over it a little bit. You'll see the ages of persons there from as early as 19 years to the 60s. You'll see the crime, some of the crimes that are being that they are charged with. Arson, for example, the mental state was imbecile. He's an imbecile. Murder, dementia, predial larceny, chronic mania, and mania is supposed to be visions of grandeur and all that, but chronic murder, epilepsy, murder, house breaking and larceny, mania, wounding mania, murder mania, indecent assault mania, predial larceny, epilepsy, wounding mania, assault mania, right? Malicious wounding mania. You get an idea of how now, fortunately for this person, by the way, now at the court in this particular case, the court declared these persons as innocent, but the mere fact that they were brought to court on these charges, right, show the extent to which lunacy is being used to solve social problems, right? And the mere fact that the asylum was now filled with more persons again suggests that many persons were charged for these crimes. And it showed also the intention of the state in ensuring that more persons were caught in the dragnet. Now, table 3 now shows, I compare table 3, the two jails, prisons in the island, and their numbers, and compare them to those going to Bellevue, which is the lunatic assembly. And you're going to see, therefore, then that when you compare that of the 14 years that I looked at, was 14 years, 10 of those years, more persons are going to the lunatic assembly, lunatic asylum, than the 2 prisons. And that's what table 3 shows. So from 1911 to 1912, for example, you see 1,439 people at Bellevue, only 1,114 at the 2 prisons. And that number increases until 1917, where more persons are now going back to the prisons than the lunatic asylum. So it shows the important role of lunacy as a tool of the colonial authorities in arresting social problems. Now, in much of if you read the reports of the lunatic asylum, the point is always made that more persons could have been brought in, admitted to the asylum, but they had problems transporting them. They even proposed at one time, this is in Kingston, by the way, they even proposed on the other part of the island, in the western part of the island, to build another asylum in the western part of the island, because the cases were so many cases. If you're going to use the lunatic law to deal with social problems in that case. No, what they also did as well, they also intertwined all the laws, the Obia laws, for example, is a good example. Obia law, the vagrancy law, even medical law, medical bill, for those who say they are practicing medicine. So they combine all those laws. But if you look at the revised laws in the 19th century, the Obia law was first passed in the 1760s. But in the 19th century, they revised it 4 times. 1857, about error right there. It should be 1892, 1893, 1898. Let me just read what the Attorney General said about the revision in 1898. He says, this revised act is intended to capture all those street preachers who constantly held meetings in the street of Kingston, howling like devilishes and doing their devil-like dance. He stressed, when they dance and howl like devilishes, and they gave water in little bottles, which are supposed to have magical powers to the disciples. And obviously, if you know, to that Bedouin, you know, they're targeting Bedouin here. But it's quite clear that the African culture, the idea was to erase as much as they could African culture. You know, Africans like to dance and sing, and you know, we are very expressive people. So all these people who are keeping meetings in the street are going to be classified as lunatic. And that's why they are swelling the asylum with many people are saying, but categorized as insane. Coming toward the 20th century, then they revised what they call the Medical Health Act, and based on what they say as improvement in cases in England, where you're moving away from incarceration or custodialization to a more kind of more progressive system of care. The Jamaican government passed this Mental Health Act. But by 1970s, one of our major psychiatrists, Frederick Hicklin, argues that by 1970s, nothing had significantly changed in Jamaica, as the asylum had over 3,000 patients living in appalling conditions. The doctor-patient ratio was poor, he says. Patient never saw a psychiatrist for months, sometimes even years. And the place looked like a prison in terms of the bars and the walls and everything. So, you know, so he argued then that it was still a period of what we call incarceration. So the only change he said was that the prisoners were allowed more time outside to plant their little gardens and all of that. But then some people argue then that they had to plant their gardens to ensure that they could even eat. So there was a case that it was more for health care. No, since the asylum remained a place of social control, there were other notable African Jamaican leaders who also resisted colonial culture, such as Leonard P. Howell, the major founder of Rastafari religion. He too was targeted and experienced a charge as a lunatic as well, including other persons as well. But for Dunkley, historian Dave Dunkley argues that Howell was confined to Bellevue twice, 1939, 1938, and 1960. Rastafari scholars Stephen Davis and Helen Lee highlights Howell's 1938 trip to the asylum. They state that, and if you know about Rastafari, you know that the first big movement for them started in St. Thomas. The police destroyed the settlement in St. Thomas. So Howell now moved back to Kingston. This is what the historians wrote. When he returned to Kingston on Monday, Howell found the police watching his house. The pressure was on. They had to get him now. But this time, they wouldn't get him a showcase trial because he's been in prison a number of times. This time, they said no then. It was time now to carry him to the asylum to have him locked up as a lunatic. In 1938. In 1960s now then, after the police destroyed what is called Pinnacle, which was the highlight of a communal setting by the Rastafari community, after they destroyed it, they are again rearrested Howell this time now and sent him to prison, sent him to the lunatic assembly, where he stayed a long time. After his release, he died just after that. Similar to Bedouin as well, he too died also in the asylum in the 1930s. So I'm going to come to a conclusion now then. Lunacy laws were one of the many tools the colonial authorities had in their toolkit to enforce public order. Lunacy became most important and an easy classification for all colonial dissenters. In the colonial imagination, you must really be mad to defy their civilization mission, right? As they sought to eradicate all aspects of Africa out of the African population, so they could embrace England and its culture. Public order demanded their incarceration and their confinement. Thank you very much.
Thank you so much, Dave. I think this is part of what we don't actually get to engage with on a regular basis. That where mental health is concerned, we were being used many of our ancestors used as, I want to say guinea pigs, but that's not the word I want to use. In fact, they went to know, you know, I'm lost for words because this is something I'm so passionate about, that our ancestors, our Black people all over the African diaspora, in fact, but certainly in the post-colonial and colonial times, lunacy or mental health taken for granted and the oppression meted out to us in institutions like mental asylums, precisely as spaces of shuttering, spaces of supposed custodial care, but really were spaces of incarceration. And I'm happy about the work that you've done and the fact that more persons, those persons present here on this webinar, but even beyond now, when we post this webinar on the YouTube page, that more persons will be able to have information about this kind of 19th century, even 20th century space. But I want to ask you, Dave, let me start with you. To what extent have you looked at the ways in which these laws still exist? The Obia law, the lunacy law, in a kind of, let's say, a sort of cocktail of suppression for Blacks in this time?
Thank you for that question, Sane. It's a lovely question, I must say. And I don't have the full answer to that question. What I can say that the lunacy law was changed in the more in the 1970s as the more nationalist psychiatrists who took over, like Hicklin and others, changed the concept now from being in custody or being at a place for more communal household care. And that's why Bellevue was eventually closed. And the policy now was to have community health, community mental care, and also household care. And that is part of the whole nationalist agenda in the 1970s by progressive psychiatrists such as Professor Hicklin. The Obia Act now is technically still on the books. And that's something that I have to look back some more on, but it's still on the books. And what is so interesting now that today, you know, a person don't even want, a lot of Black persons still don't want to have it removed because they still see it as something that is bad. And we realize that it was really there to catch. If you look at the revision, by the way, they kept ensuring that even people who could slip through the cracks, they could find a way. At one time, they even had a thing called the instrument of Obia. So even if you're not an Obia person, but if you had the instrument, for example, like a feather, like a thing, and they see with the feather, you're captured. So they found ingenious ways to recreate and rewrite the acts. And I can follow that up some more to see where we are today. But I know for the lunacy one, in the 1970s, they revised the Mental Health Act to get away with custody and to have more family and household and care.
Thank you so much, Dave. Perhaps I might ask questions of each of our speakers at this time, or anything that you might want to ask each other that has emerged. You can let me know. But Judith, I really wanted to get back to you to look at this fantastic research that you all have conducted in the context of the team, and these sort of compelling statistics that show this discrepancy in health. And I'm wanting to pose this as something that we need to look at and we need to replicate, not just in the context of Haiti, but also, let's say, Jamaica, Barbados. What is the life expectancy, including for women, children, NCDs, cardiovascular health, for example. And even you mentioned armed violence, things like mortality rates, to what extent femicide and gender-based violence as well, in the disparity between France versus colonial and contemporary Haiti. This is the kind of research that we need in the other territories, certainly within the CARICOM region. And I wonder if you could say a little bit about the work you're doing as part of the Reparation Commission, the National Reparation Commission, and how that's translating in a regional context?
Yes, absolutely. Thank you for bringing this to my attention. So our committee was created in May 2024, and it was basically, that doesn't mean before April 2024 when those 20 Haitian NGOs went to the United Nations within the context of the Forum of People of African Descent. Then they claim restitution of our independence ransom. So that was a really important moment that I think led the head of the State University of Haiti to create that committee finally. Although everybody, like people like me or the Haitian scholars, we were writing, we were talking about reparation, but our voice were not really heard. So in May, they created that committee, and then so I was fortunate to be one of the first person that they called to be part of that committee, and I helped a lot actually to structure the committee, and I was the one of the leader who proposed that, okay, as I said in my presentation, because I was already doing that work, my work is really centered around health disparity, historical context, health disparity, and health equity. So, and I knew the data was there, but someone had to dig into it, right? And so I proposed that we created a working group within that committee to specifically focus on studying, exploring, raising awareness, advancing data on historical trauma, multi-generational trauma, or multi-generational healing as part of the Haitian reparation and restitution movement. And so since it's something that I have always been passionate about this, I have been working in that field over the past for at least a decade, right? So I already had that platform, the Haitian Wellbeing Study, that was launched at the University of Miami 3 years ago, with the goal to follow a cohort of 1,000 Haitian in the US and in the Haitian diaspora in Haiti and also in the US. So it was a beautiful opportunity for me to offer the committee in Haiti to, okay, I will gladly of opening my platform for you, because we were already collecting genetic data. We were already collecting multi-level data to explain or to explore multi-level determinant of mental health, of well-being among Haitian. So that was just like really easy for me to just like, you know, tweak the Haitian Wellbeing Study platform and make it a part of that committee. So last year we conducted focus group with Haitian people in Haiti and also in the US. And one of the goals was to really gather their feedback with regard to if we were to rebuild the system in that moment, and if we were to create a mental health program to help tackle the mental health crisis going on in Haiti right now, what would be your suggestion? And so we have a lot of beautiful insight, including insight with regard to the first insight. The first recommendation was mental health, was to basically to reestablish security. Everybody say you need to take care of our primary needs first. You need to reestablish security. Guns, the gangs, I can't sleep, I can't go out, I'm depressed. So all types of those complaints, I took them into account, and then that was based on that. I really like built, this insight, this analysis based on the result I got from the focus group. And really, I would say it's a work in progress. I'm happy to share, to collaborate with other scholars in the Caribbean, in the US, at the Center for Reparation Research. It's a work in progress. I would be more than happy to, to open my methodological framework to you. If you want to replicate the same analysis, the same work within the context of Jamaica and other Caribbean country. Yeah, but again, it's not done. It's really in progress.
Preliminary results. So we will take you up on that offer, because one of the things we are establishing at the University of the West Indies through the initiatives of the Center for Reparation Research is a research cluster on reparatory justice. I think it's very important. And in effect, without using the same language, Dr. Blanc, this is exactly what you have done, in a sense, to engage with the research, which must drive the efforts at reparatory justice. Dr. Krieger, I wanted to just come back to you also, and I know there are questions in the chat that we're going to get to, but I wanted to have you respond to just a query in my own mind about what you might be seeing as distinctions between health injustice, certainly in the United States context, versus any space in the African diaspora. And I wanted to just to get back at just the way in which we may be so focused on the African diaspora and certainly the post-colonial societies, but not necessarily focused on, let's say, the kind of health injustice that's taking place in spaces such as the United States. So, and I'm not losing the fact that it's also a post-colonial society.
Right. I mean, understanding anything in the U.S. means understanding first what happened as being established as a settler colonial society that also was a republic that established slavery as being legal in much of the territory, and then the consequences therein. So, and the slavery that was done was involved predominantly bringing in the African slaves, but also the indigenous population was enslaved, and that there's different histories of what happened going from in the East Coast, and then also what happened coming up through the West Coast, and what happened with the Spaniards and et cetera. So the U.S. is very complicated, and what the U.S. is complicated. When was Mexico broken up and part of Mexico stuck in the U.S.? So it's hard to answer that question easily, but I think the key point are the dimensions of what makes something a health injustice, which is that it is unfair, avoidable, and in principle preventable. And more than that, it suggests that someone is benefiting from the harms to others. And that's a part that's often left out. Often what happens in the work is it's a looking at what gets called quote unquote vulnerable populations with no real explanation of who is vulnerable to whom and why. And I think a key part that certainly comes across in the anthology that we've put together and much other scholarship is that it's beyond coming up with compendia of what are different observable differences, assuming you trust the data. I'll come back to that in a moment, between groups, because it's why do those differences exist and when do they become inequities? Because there is such a deep, long history of scientific racism that was absolutely fundamental to the ideas and ideologies in the transatlantic slave trade and elsewhere of saying there's innate biological differences. And if you see differences, whether in quote unquote lunacy, whether in health status, whether in anything else, it's because some groups are inferior and others are inferior. And that if you have superior and inferior groups, a priori genetic determined, that it's not social conditions, this is the way people are. So you can have two different groups of people look at the exact same data of difference, the higher mortality in one group, lower in another, and have completely different interpretations for why. And the science comes in testing what those interpretations are. The science comes in and refuting the myths of genetic determinism, biological determinism, innate biological inferiority, the very idea that there are distinct human races that can be neatly cleaved into different groups, and not understanding the complete heterogeneity of humans all over the place. If there's one thing humans do is they wander around and they have kids with other people. So there's quite the mix of people on this planet. So I think it's really important to have that. And that's why, again, a key insight about tackling scientific racism is crucial to the work on health inequities. And in the US, that also plays out in terms of other kinds that's played out in the eugenics movements. If you're looking at the negative eugenics in terms of class differences that cut across all different racialized groups, it's about understanding the racialized process itself. It's about understanding the links between the economic conditions and the racialization and how the material conditions of people's lives affect their health, good and for bad. So I think it's all those different things. And I think the other thing is that for any given outcome, disease, exposure, et cetera, it can be twisted in different ways depending on who's trying to explain what. So it's interesting for me to hear, for example, your discussion of lunacy in Jamaica, because a very famous episode in the United States was 1840. And it was at the 1840 census when the census results, due to actually incorrect data that were due to error, not deliberate bias, ended up making it look that there were higher rates of insanity among Black people in the North compared to those in the South. And that led to the idea that the people that were pro-slavery, particularly Calhoun, said that, you know, freedom drives Blacks mad. They do better in the South. And so that was one of saying, actually, that freedom made Black people insane. And what really happened was that, one, in the South, there were not the lunatics that were counted, so-called, because of segregation. There were no places for Black, quote unquote, lunatics to be put. The white people were the ones that were institutionalized. And in the North, what happened, there was just very messy category, the ways the columns were arranged in the census, that there were more counts of people that were labeled as Black lunatics, and there were actually Black people living in the different towns. So it was a complex mess that when it got figured out, it led to actually major changes in how the US Census was conducted and how the data were conducted. So it's a big lesson in saying that a term like lunacy can be applied in different ways, depending on what the political interests are, and that you always have to look under the proverbial hood to see if you even trust the data and understand all the different ways that problems can lead to having faulty data that just go with people's preconceptions of what the data should be, and instead engage really truly with how the world is. And that's key to changing the world for the better.
Thank you so much for that response. It is indeed that there is the politics of data and, of course, the politics of agendas, whether it is to suppress Blacks, which is really what we're talking about. You know, I heard you talk about the Blacks in the North being more prone to lunacy because they had more freedom. It is always underlying all of this is about suppression. And I want more persons to become aware of this, that it is historically there, and in our contemporary societies, it is also there. Some of these laws, Jamaica is not, for example, many Caribbean territories are not taking the example of Rwanda by repealing colonial laws that no longer serve us. So there's a reason we are not doing that. The kind of constitutional reform that would allow for the transformation of these societies, whether in terms of public health or otherwise, these things are not being done. And that's a political will question. Is there political will to change, to transform these societies appropriately for the people who live in these spaces, considering their historical oppression or not? This is a question that confronts us. And part of our challenge is obviously to engage with, quite frontally, the ways in which our societies are not serving us. So let me go to the chat. There are some questions. Thank you so much to those who have posted questions. How do mental health challenges in post-slavery societies differ from those in other marginalized populations? I don't know if anyone would want to tackle that. I think we did cover some
what is the question
of
again? I can see it.
How do mental health challenges in post-slavery societies differ from those in other marginalized populations? So let's take indigenous peoples, for example, or indigenous groups. In the United States, we could talk about the American, the First Nation peoples. marginalized, we could also talk about Black women as a particular kind of group.
So I'm gonna try, but that doesn't mean that I have the answer. But in my own research as someone who was trained as a clinical psychologist, so I pay really a lot of attention to social determinant of mental health, such as racism, racialization, gender oppression, gendered racism, class. So the intersection of your identity or strong determinant of your mental health. That is to say that so the situation of stress, the unique stress I am experiencing living in America as a Haitian immigrant, non-native English speaker, coupled with multiple other identities or unique to me, right? So compare Native Americans, they absolutely, each group based on their identities and also based on specific resources they have access to, as well as historical event that happened to them, they are confronted with specific stress. So that's why it's important to put that's why I pay a lot of attention to unique stress responses, because most of the time, as Dr. Ghost mentioned, those mental health label, mental health diagnosis, they are responses, unique responses that those population, marginalized population, non-white population, that's their way of reacting to trauma. And that's where the trauma movement is super important when it comes to our understanding of mental health right now among Black people, Native people, or non-white, non-Western group in general, because most of the time you're gonna realize that, in fact, those people that we are labeling as psychotic, or those people that we think that are depressed or that are suicidal, they are just, they are just overwhelmed by the system, by a racist, unequal system. So that would be my approach to your question. I don't think I have like a specific data or statistic to provide at that moment.
Thank you so much, Judith. And yes, we are about to close off, but let's just see from the chat whether there are any questions we would want to respond to. For Nancy, what role does language and historical framing play in addressing the legacies of slavery in public health?
I think that, again, and this builds on what Dr. Blank was just saying, the history matters enormously to understand the specificity of the kinds of exposures that people have had. The social exposures, the cultural exposures, for good and for bad, the biophysical exposures, including the environments in which people live. That historical specificity matters, because you can say, yes, in general, injustice harms health, but if you're trying to understand specific populations at specific times, you're going to see different kinds of diseases happen, and you need to understand that in relation to the specifics. When you have lots of petrochemical plants, you're going to have certain kinds of diseases that arise because you have that as the exposure, and the environmental injustice is tied very much in the US when considering the story of the Louisiana Cancer Alley and down the Mississippi, where the plantations were, has often been where the petrochemical industries have gone in and created their refineries. There's water pollution, air pollution, and soil pollution. So there's a specificity that comes with understanding the history that shapes the context in which people actually live. That's really important. The language, in science, you're supposed to try to use terms accurately, and you can see the amount of inaccuracy in terminology. People use quote unquote race without any definition. They think it's a self-evident term. It's not. The language has shifted increasingly in the scholarship that I'm aware of to racialized group to make it clear that people have been racialized, not that races quote unquote exist a priori. And then you have to ask the questions, what are those conditions of that process of racialization that lead to the kinds of health inequities? So as I said, where framing comes in is fundamentally and doing critical science versus not, and doing science that can deal with the fact and understand the legacies of scientific racism and challenge it in the kinds of work and then the kinds of data that are needed. In some of my current epidemiologic work, for example, we are looking at multiple types of discrimination measured in multiple ways through what we get through individuals, both self-report and using implicit association tests that we've adopted to actually being about people's being a target, not just what their internal views of their own self are. And then at the same time, also getting structural data on the conditions in which people live and other kinds of contextual data. So the scientific work of challenging scientific racism and of doing anti-racist science is much more than just about language. It's about actually what are the theories that we use. I'm guided by the ecosocial theory of disease distribution that I first proposed in '94 and have elaborated since, that really brings in these questions of levels, history, accountability, and agency. And there are ways that you can structure thinking, and that's what drives it, not words. Words can mean lots of different things to lots of different people, and you can have the same word used in the United States. You'll find people use words social determinants of health and treat them just like a bunch of risk factors versus understanding the social determination of health and who is setting up and benefiting from the social systems that create poverty for many and extraordinary wealth for few. So it's not the words, it's the framing. And then you use words to express that, but you have to be really clear on what you mean and having injustice and opposing injustice at the core of the science itself.
All right, so let me come to questions that have been posted, Dave, before I ask each speaker to sort of give us a closing statement. Dave, can you speak to the role of Christianity in supporting such lunacy and anti-obia laws? Then and now, how should Christians approach this issue today? And there is, in fact, another comment for you. Dr. Goss's presentation brings to mind the 1851 term drapetomania, based upon the hypothesis that only mental illness would cause enslaved Africans to want to flee the civilizing improvement of enslavement. Is there an associated psychiatric term to describe the colonizers' delusion of the benefits of chattel enslavement? And I just want to help to answer that, Dave, so you can focus on the Christianity question.
Yes.
And indeed, and in fact, where we don't necessarily have a term as concise as drapetomania, certainly you want to examine Professor Freddie Hickling's work on the very delusion that is undergirding the white supremacy project, where he talks about psychohistoriography and his publications that justify that big delusion that undergirds the Christopher Columbus project, the whole project of enslavement, and before that of imperialism, really. So I want to commit you to the work. I want to commit to your memory then, the work of Freddie Hickling. Please do read on that. But certainly, Dave, open to you to respond to any or both.
No, man, I leave you for that second one, which you answered well. I just thought about Franz Fanon as well. If Fanon work would also help with that as well. But the first question, yes, the Christian church was highly a colonial church, and the dissenters would have been, people like Bedward and other black nationalists are dissenters. So the Christian church was very much a part of the colonial project. But things changed coming towards the 20th century. Things changed to that to some extent. But the second part of your question, though, is what is also interesting, because remember now, the Obia Act was first passed after the Taki Rebellion in 1760. And the idea that Africans have this weird kind of magic that will destroy white people more so. So you pass Obia law and you strengthen the Obia laws. Just to make the point very quickly then, that remember Obia is a form of healing for Africans in response to two things. In response to a new environment that they are now in, this kind of slavery colonial environment, one, but two, also in response to their own understanding of the spirits, and because in African societies they don't have this thing called good and bad. They don't know good and bad. People will do bad things, and so there are people there who might do bad things to you, and what your response then would be is to consult your healer, which is, I said, the Obi man. So you could see how the colonial people could take that and frame the Obia man as the devil, but traditional person, African healers provided that work, and in the Americas, that's why we have so many African religions in the Americas, because Black people to find a way to provide their own mental health. So the Obia man helped them in their mental health, whether it is voodoo, revival, and so it was part of our own way of healing. What is needed now is a discussion now among Christians today now as to what Obia really was and its role, and why we must repeal the Obia Act. So more discussion is needed.
Thank you so much to all our presenters. Now you have a minute. Any closing remarks, closing comments, anything you want to pick up from each other's statements? Now is your chance, in no particular order.
I mean, I would just probably make the point that what I think is needed now, a comparative work, Haiti, United States, Caribbean, and also interestingly now, what do the data show for Africans now then who have also been colonized? That would be a kind of cross comparative. I think that would be critical.
Definitely, and I was about to make a statement about that earlier, but I'm glad you brought it up. Dr. Blanc?
So from my end, so that was really a very inspiring, insightful webinar. Thank you for inviting me. I learned a lot about what was going on in Jamaica, and I'm glad it aligns so well with my own research interests. And I really would like to put the emphasis on specific concepts such as the biopsychosocial and ecological paradigm that I brought up, and how important it is, because the global movement for reparation is gaining a strong momentum. And from a political standpoint also, we know we have some challenges that we're gonna have to face. So I would say, let's try to see how we can keep this interdisciplinary approach, more science, scientific data, more empirical data, interdisciplinary collaboration, international collaboration. So let's make it happen. Let's continue to come together, ally, people of African descent, people of color, continue to stand together, including scientists like me, biobehavioral scientists like me, to advance the cause of reparatory justice for people of African descent and every single indigenous people that are still burdened by what happened 300 years ago in America. So, and also I wanted to continue to provide support, that I'm open, my doors are open, my lab is open for collaboration. So I look forward to working with you in the near future.
Thank you so much. Nancy, you have the last word from presenters. And I know you are seeing that we have so much work to do at the level of the International Scientific Committee of UNESCO's Roots of Enslaved Peoples Project. So much work.
Right, and so I think just speaking from that, I was really glad that that project from UNESCO allowed us to pull together the materials that we did as an interdisciplinary, geographically dispersed group of people to really start to put some of the scholarship together that connects across the different disciplines to get a deep understanding of the long critique of scientific racism, the long critique of the harms of the slave trade on people's health, understood at the time, it's not a new idea, and continued to the present in terms of the harms to people and the lands in which people live. So I just think that it's really important to bring this evidence together and to have different kinds of groups come together to have it available, because all too often health issues are looked at as just a contemporary problem, not that they have deep historical roots. And just because they have historical roots doesn't mean that they're directly inherited as biological properties from one generation to the next, but rather the conditions in which people live and the ways they have been shaped by those conditions matters from one generation to the next. So I think bringing that together, as well as the empirical quantitative work that's necessary to show the magnitude of harm and the harm that persists, from the standpoint that it could be prevented. And that's what I think is a key element going forward.
Oh my goodness. I am sure that everyone who has been on this webinar has been enriched in terms of further information, additional insights, new ways of conceptualizing this very issue of public health, and how deeply connected it is to how we live our lives in an epidemiological context, psychiatric context, just thinking about mental health in our own societies today and the kinds of stigmas attached to mental health, the way in which we have in fact been approaching mental health even in our contemporary societies in a colonial way. So I want to really thank each of you, to say you have in fact exceeded my expectations in terms of just the kind of conversation we have had today, that public health and the legacies of chattel slavery is a necessary conversation, is a conversation we must continue to have in an interdisciplinary context, but also as we move to strengthen the reparations movement in the African diaspora, in the Caribbean region, and certainly in the United States, and to advocate for accountability in that repair. So the case must be made to France, to the Netherlands, to Britain, etc., that yes, there is a claim that must be made and one that needs to be attended to. We are about reparation. We are about repair. We are about transforming our societies with human dignity for the people who live in this region. So join us again for another in the series of webinars that we bring to you from the Center for Reparation Research. Follow us on Instagram, CRR_UWI. Follow us on X, formerly Twitter. Stay tuned to what it is we do by way of research, by way of advocacy, by way of education, in terms of our own mandate as the research arm of the CARICOM Reparations Commission. See you soon again. Walk good and have a wonderful weekend.
Bye-bye.
Bye-bye.